I think anyone who's ever considered the term Zoom fatigue is familiar with this concept.
Yeah.
The idea that a two-dimensional interaction with a person where you're seeing, this part of their torso and their head is not capturing the full depth of the experience. It can be a challenging thing to try and engage on a deep level with somebody when you feel that digital distance from them. Especially in mental health, where we're talking about pretty heavy issues. When we have these heavy topics, you really want to be able to connect with the person that you're speaking with. And I think VR is one of the most innovative ways of doing that.
Welcome to another episode of Mental Health in the Age of the Metaverse. I'm your host, Christian Ulstrup. My guest today is Dr. Nikhil Nadkarni, goes by Nick. Nick is a board-certified child and adolescent psychiatrist, as well as the medical director at Little Otter Health, a personalized online mental health care platform for children 0 to 14, designed by the world's experts in childhood mental health and delivered fully virtually through their state-of-the-art platform to the comfort of your own home. Nick, welcome to the podcast.
Thanks, Christian. Appreciate you having me on. It's exciting to be able to talk about technology and virtual reality. It's something that I've been passionate about for a long time.
Well, I'm really glad that you could join me today. We have quite a few interesting topics to talk about. So first, tell me a little bit about Little Otter. What do you do? What is the company's approach? How is it different than what else is on the market?
Yeah, so Little Otter, like you said earlier, is a personalized mental health care platform for children and really for families. And, we are unique in that many other systems that might provide mental health care are focused on individuals. These, a family might have a child that's really struggling with depression or anxiety or ADHD, and they might bring that child in for care. But in doing so, the focus is purely on the child. But while that may be beneficial for the child, there is also this kind of underlying aspect that gets missed in that any mental health disorder does not exist in just one person. It's diffuse and it affects the entire family. So, a child with anxiety might cause problems for the sibling, may cause problems for the parents. And so, when we assess a family, we come in and we don't look at just the problem child, so to speak. We look at the entire family and we do a comprehensive evidence-based assessment to determine what are parental stress levels like. Maybe, many of the things that we diagnose in children are things that have a genetic predisposition, things that might also exist in the parents. And so, with our approach, we really look at being comprehensive to provide mental health care for the entire family. And that mental health care comes in a number of different forms. As the medical director and director of psychiatry, my focus is, of course, on medications, because that's what psychiatrists do. But we also have therapists, psychologists, social workers, as well as board-certified behavioral analysts. So we provide parent training for parents that don't know how to manage challenging behaviors. We provide individual therapy, couples therapy, family therapy. And then in addition to all of that, we provide medication management, which is really what my job is. So the nice thing about Little Otter is that we can get all of these things in one place basically a way to support the entire family's mental health all at once.
Interesting. And this family approach, if I were sort of in the audience and maybe I had not seen a therapist before, in that capacity, sounds like it's pretty different than maybe traditional like talk therapy. So you kind of think you go into the room, sit on the couch, talk for 60 minutes, and that being kind of the standard approach. What is it? How is it different when you're taking this holistic view of the family in practice? Is it is talk therapy still at the core of it? How does that actually work?
Well, all of the different modalities that we use are, put a heavy emphasis on being evidence-based. So it kind of goes back to the original founding, the story of origin for Little Otter. It was founded by a mother-daughter team. Our CEO is Rebecca Egger, who has experience in the tech world and has worked at Palantir previously. And then her mother is actually our chief medical officer, and that's Dr. Helen Egger, who, has been, for the last 3 decades, one of the most active participants in academic medicine in child and adolescent psychiatry. She was head of the Department of Child and Adolescent Psychiatry at Duke for 20 years, and then again at NYU for 5 additional years. So with that kind of core of our founding team, we have really emphasized being evidence-based in the care that we provide. And so what that looks like is not necessarily just kind of typical play therapy or talk therapy, but we choose modalities for therapy and for medications that are really well supported in the medical literature. So for children with anxiety, for example, that might be cognitive behavioral therapy, which is a structured form of therapy that, has a certain number of sessions, teaches very specific skills, and is really well supported in the medical literature as something that produces great outcomes for people with those types of disorders. The holistic approach that we have means that when we see a family, we, one, are looking at every member of the family to see if these things exist in multiple people. But two, we are implementing evidence-based treatments at multiple different levels. As a psychiatrist, people often ask me, do you just think that medications are the solution to everything? And the truth is, no, I don't. Medications can be a really helpful tool when we're combating mental health issues, but medications are only a piece of the puzzle. It's really important to also recognize that evidence-based therapies like the cognitive behavioral therapy that I just mentioned, or parent training approaches like parent management training, these are also important parts of how we provide care. And so if you look at studies of mental health outcomes, it's really been shown that having multiple things at once, having the therapy plus the medications, produces better outcomes than either of these things by themselves.
So it's holistic, not just in taking the whole family into account, but all these different tools that you have at your disposal.
Exactly.
Many of which are scientifically validated.
Exactly. And then on top of that, we track over time as well. So it's not just that you are having an intervention, but we also use validated measures to be monitoring what the progress is for care. Because if we are applying an intervention like a medication or a therapy, we want to see if it's working. We want to be able to prove that the thing that we're doing is producing the benefit that we're looking for. And so we track care with validated assessments at different intervals throughout the time that we are seeing children.
Okay. That makes sense. So if there was a parent who was listening right now, it's getting to be the end of the summer. They're starting to think about, what they need to do to plan for back to school and everything else. Of course, kids can be difficult, get into trouble, in that range of 0 to 14. What is the point at which it's, sort of appropriate to seek like clinical intervention?
Yeah.
What's the difference between difficult behavior and then, requiring the services of a Little Otter provider?
I think that's a really great question, and it's a hard one for a lot of parents to answer. The nice thing about Little Otter is that we've actually developed a couple of different toolkits to help with answering that very question. So we have a back to school toolkit. We have a tantrums toolkit. You can go onto our website, Little Otter Health. And at those, on our website, you can take one of those toolkits and it'll actually tell you, is there a concern? Is there something that we should be worried about, and help answer that question? Because it's really nuanced and it's based off of the child's developmental level. It's based off of their environment. It's based off of the types of symptoms that they're experiencing. And so even experienced clinicians may have a hard time telling a family what to worry about, unless they do a really deep, comprehensive assessment. So starting that process by filling out one of our toolkits is a great way to get a grasp over what the concern is and whether it's appropriate to bring in an expert like a member of our team.
And that's available on your website?
That's available on our website.
Cool. We'll put a URL in the notes as well. So awesome. So, I asked about, what were some of the things that make what you guys do unique versus some of the other approaches in the space. I think over the last few years, the sort of mental health space has really intersected with technology. There's been a lot of venture capital that's gone into some of these new approaches as well. And I think, sort of more recently over the last year or two, there's also been some concern by different stakeholders about, how these experiments are panning out around safety, around, whether or not certain approaches are working. What does it mean? The role of regulatory agencies, interstate care is always sort of a big issue. So going virtual, like, how do these things collide? What do you think about what's going on as we've learned from some of these experiments over the last few years?
Yeah, I think it's a great question, and it's one that I've been asking myself a lot lately, and will probably continue to ask for the next several months or even years. I think with the COVID-19 pandemic, there was a big shift, especially in mental health, where the pendulum went all the way in a different direction. Where I haven't personally seen a patient in person since March 11th of 2020, which is, given that I've seen thousands of patients, is kind of an astounding thing to consider. And with those changes, with that shift, kind of almost overnight from care being provided mostly in person in mental health to being provided almost entirely over remote things like Zoom or virtual reality. With that big change, a lot of regulations, especially in the medication space, had to be put on pause. There are some regulations about meeting a patient in person before prescribing certain types of medications. And so what ended up happening is, appropriately, when the COVID-19 pandemic happened, we needed to make sure that people were still going to receive care. And so some of those regulations had to be put on pause because it wasn't safe to meet in person. What happened after that, though, is that with that regulatory pause, there were opportunists that saw this as a chance to maybe take advantage of the things that the regulations were designed to protect against. And so there has been a lot of press lately about some of these companies that maybe have had less than ideal diagnostic processes, less than ideal follow-up for care. They might be prescribing medications on the basis of a very short visit, or without really doing a rigorous assessment to determine, is that the diagnosis or not? And where that can be problematic is that a lot of these medications have significant side effects. A lot of these medications can be dangerous if misused or if prescribed to a person who has an underlying problem. A good example is somebody who might have a cardiac issue and is taking a stimulant medication. Those are things that we have to assess because it can be dangerous for a person to take that medication. And so when companies prioritize profit and bringing in as many patients as possible over providing appropriate care and stewardship and attention to those patients, that's where we see this process break down. What's been exciting about being in this space is that the companies like Little Otter that are really focused on producing excellent outcomes and excellent care, and are following the institutional guidelines from organizations like the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatrists. Organizations like these are able to provide a very high level of care despite being virtual, and we're actually able to access patients that we might not have otherwise been able to access. So the virtual care, provides a lot of great benefits, but on a government or regulatory level, there are some concerns that I still have about how this process is going to play out when the pandemic is over and the public health emergency is declared complete. And then we the pendulum starts to swing back the other way towards in-person care. And
so you highlighted a few different interesting points. One is sort of difference between quantity and quality, right? And sort of the role of technology and venture capital in that is sort of tricky because technology ideally creates abundance. You do more with less. Things become frictionless. Opens up, something that's more of a global marketplace. And everything else, but especially when combined with very high pressure around growth targets and things like that, that can sort of shift the dial between quantity and quality, which in healthcare is certainly something to be concerned about. The regulatory environment, I'm curious, and in your, you mentioned maybe the pendulum kind of swinging back a little bit. Do you foresee there being a future in which the barriers cease to come down when it comes to interstate care, or how do you think about that?
Yeah, I think
going
again,
forward?
it's a really good question that I don't know that anybody has a firm answer on what it's going to look like. The way I think about it is that, the toothpaste is out of the tube. When it comes to telehealth, and putting it back is a messy and uncomfortable process, right? Because if we were to, let's say tomorrow, the public health emergency was canceled, and then that means 60 days from tomorrow, the regulations would go back to normal, unless there's something else that, to the state that they were in prior to the pandemic. In that time period, hundreds of thousands, if not millions of people are going to lose their mental health provider, or going to have, challenges in receiving the same amount of care, because telehealth has been the norm for the last 2 years, especially in mental health.
Yeah.
And so it's not the kind of thing that you can, simply just return back to the old way of doing things. There has to be some sort of graded approach. What I'm hoping for is that where we land, we find, we find the right balance between providing access so that people can receive this type of care, but also balancing the risks and concerns that have come up with some companies taking advantage of the regulatory pause. So my hope is that we land somewhere in between where we are right now and where we were prior to the pandemic.
Makes sense. So you've seen, did you say over 2,000 patients?
I haven't counted exactly. I know it's over 1,000 between adults and children. I've had over 1,000 patient interactions since the pandemic happened. So that's
quite a few.
It's a lot. And with that, it's actually given me a lot of really interesting insight on how this modality is unique and different compared to in-person care. So, prior to March of 2020, when I would see kids, I would see them in my office, and I have toys, and I try to make it a fun office, and I have art and things like that, but it's not the same as being at home. So when they come in, the family, is often stressed. I live in Los Angeles. They are having to travel through LA traffic and then find parking in LA and then get to the office, try to be on time. They're often very stressed coming into the office. And then when they come in, they're in a sterile, controlled environment that doesn't really accurately represent what the home environment looks like. Now compare that to what happens in telehealth visit, where I meet the family, they're doing the call from home. They're in their space of comfort. The child doesn't have any increased anxiety about being in a new place. The parents are not stressed out about traveling and finding parking and being on time, because it's fairly easy to do that. Parents can join from multiple locations. It's common for me to have one parent at work and one parent at home, or parents in different states, and still able to participate in care. And then when it comes to working with the child is in their home. I sometimes, if the family does a Zoom visit on the phone, sometimes I have them hold the phone and give me a home tour. Or, I regularly have the child bring one of their favorite toys and they tell me about their favorite toy. And it allows for visualizing the child and the family in their natural habitat, in their home environment. And it provides for a lot more useful clinical information than I might get in the sterile environment of my office.
So is there any reason to go back to the office?
There is the flip side to it. And actually, I think virtual reality is an interesting response to this flip side. But the other side of it, and I think anyone who's ever considered the term Zoom fatigue is familiar with this concept. Yeah. The idea that a two-dimensional interaction with a person where you're seeing, this part of their torso and their head is not capturing the full depth of the experience. There's body language, there are movements, there are aspects of motor and physical orientation that we cannot, fully attend to in a meeting like this. And so there is something that is absolutely, and then just kind of the three-dimensionality of it. There is something that feels artificial about these types of interactions, and that adds to additional social fatigue for many people. It can be a challenging thing to try and engage on a deep level with somebody when you feel that digital distance from them, especially in mental health, where we're talking about pretty heavy issues, self-injury, like really significant mental health concerns, severe diagnoses, things like that. When we have these heavy topics, you really want to be able to connect with the person that you're speaking with And there is a little bit of additional distance that happens with remote care, that we need to find creative ways of solving that problem. And I think VR is one of the most innovative ways of doing that.
It's probably a good segue to, virtual reality is something that we initially connected on. You actually gave a presentation to the UCLA Psychiatry Grand Rounds on VR.
I did, yeah.
Is that right?
Yeah, that was about a year ago, a little bit over a year ago.
It's about a year ago. So you've been thinking about VR for a little while.
Yeah, I grew up in Silicon Valley. Everybody in my family is in tech. I'm the only one who went into medicine. And so, I've always had a little bit of that tech junkie in me. But I remember first being amazed by VR this is a long time ago, but when Google Cardboard came out and you could make your own little box and then insert your phone into it and, be able to, suddenly kind of be in a different place. I thought it was really unique and interesting technology. And it wasn't terribly sophisticated. I mean, it was literally a cardboard box, and a phone, but, even just that simple thing, really sparked my interest because you can forget that it's a cardboard box. You can forget that it's just a phone. And so as I've been following the technology as it's gotten more sophisticated with, the Oculus Quest, and become more portable, more accessible, to the everyday family. And, the idea of the metaverse and being able to combine my recreational interest in virtual reality with my professional interest in providing mental health care to children and families. That was really what spurred the decision to give that presentation at UCLA.
Excellent. And now, about a year later, you've had the opportunity to actually try it out in clinical practice. How did that go?
I want to say I'm really grateful to you and to Virgil's for giving me that opportunity. I have been thinking about this for a long time, but it wasn't until a couple of weeks ago that I actually got to have my very first virtual reality interaction with a patient using your platform. And I just got to say, I was blown away. It was so cool. And I wasn't the only one who felt that way. The way we did it was I have an Oculus headset. With the family that I was meeting with, I generally meet, it's a 9-year-old boy, and every time I met with him over Zoom, he would be really interested in talking about virtual reality, and the games that he would like to play. And so, that became a repeated topic of conversation and something that we shared an interest in. And, actually getting to meet with him in the virtual space. He had his Oculus headset, I had mine. And then his mom also joined the session, and was able to participate using the browser, but still be there and be engaged in the process. All three of us found it to be really fun. We played around with the different objects in the space. The space was designed to be like an office, and so this is a kid who on Zoom was having a really hard time answering questions, would get distracted, would get disengaged from the meetings. In this space, he was excited to talk about, the different things that were going on, how he was doing on the medication, what his symptoms were like. And we kind of experimented a little bit with a platform of different ways of interacting in that space and talking about these topics. So it was a really eye-opening experience, better than I was expecting it to be.
Oh, I'm really glad to hear that. And I'm impressed you got the mom in there as well.
Yeah. And
how was she kind of moving around? Yeah. Like how was that?
Around too. And, based off of what her, she had really great feedback for me after. She was like, I asked them, is this something that you are interested in, doing in the future? And she said, yes, she was enthusiastic about it. And I think it offered her an opportunity to connect with her child in a way that she hadn't had that chance before. And so, there's more than just the dynamic of my professional relationship with his family, but it was also within the family, their connection, was able to be strengthened through this process. So it was very, very cool.
Oh, I love that. It was coming to mind is what you mentioned about Little Otter being very evidence-based. VR in, clinical settings around, sort of talk therapy is a new thing. There's actually a lot of evidence for virtual reality as a tool in working with anxiety disorders, for use with exposure therapy, post-traumatic stress disorder, I believe as well. As somebody who's now used this in clinical practice and also is focused on evidence-based care, I'm just kind of curious if there are any research questions or anything that immediately come to mind as, where could this go? Like, what would you want to know about how VR might be used as like a new tool in the clinician's toolkit?
It's a really great question. I think what I want to try to understand is which patients, and which disorders are going to respond best to this type of treatment, and which are not going to respond well to this type of treatment. So you brought up a couple of really great points that, certain disorders like anxiety disorders and PTSD are really well suited because those types of disorders, often the treatment, the type of therapy that we provide is exposure based, meaning we reproduce the anxiety inducing or the post-traumatic stress inducing situation. And through reproducing it in a safer environment with an individual that is trained in that, a mental health professional, reproducing that experience allows for the person to kind of develop resilience against the types of typical responses or pathologic responses that they might be having. So where I see this as being particularly valuable is in disorders where the well-established treatments that we've been doing in person for a long time lend themselves really well to a virtual environment. So a great example is like specific phobia, for example. So specific phobia is a fear, a very intense fear of a particular situation or thing. These are things that many people are familiar with. A common one is a fear of flying. So if a person has a specific phobia regarding flight, we can, in a virtual reality environment, we can recreate the experience of being in a plane, sitting next to your therapist, as your therapist helps you with coping skills and helps you process the exposure of being in that setting. And you can do so without actually having to buy a ticket and be on a plane. In exposure therapy for this type of treatment, actually, that is often a piece of the treatment is actually go buy a ticket and go get on a plane and practice this. But it's not, you're not likely to be able to do that with your therapist sitting right next to you. And that's an expensive process and it's anxiety inducing for the patient. And so if you can reimagine that situation in a fairly simple to create virtual environment where you can interact with your therapist directly, remotely, it's a really, really, potentially powerful way of implementing things that we already know work. So I think that's really what I want to understand is how do we take things that work and make them fit into the virtual reality framework?
And by doing that, I'm just thinking about the plane example. You're decreasing the cost, whether it's, literally the financial cost or, having to drive to the airport and all that kind of stuff by orders of magnitude. So, and that's the way technology should be used.
Now there is also a question here though of, are these virtual experiences going to be sufficient enough to, sufficient reproductions of the experience to produce the outcomes that we're looking for? I think the early evidence definitely is promising on this. Especially in PTSD and anxiety disorders. But I think it remains to be seen across a number of different disorders, just how robust the responses are and how they might compare to the traditional interventions that we have. We don't necessarily need them to be better, but we want them to be sufficient. We want them to be good enough that they are comparable treatments to our current gold standard treatments.
Yeah. So, we've been talking just now about the potential positive roles, especially in a clinical setting, that technology can play, virtual reality. There is another side to the coin of technology, which is there are a lot of folks who are concerned about the negative impacts, especially when it comes to consumer software, young people. I think a lot of this is still being sort of figured out. You've been on the front lines as a mental health professional, especially in kind of this post-COVID world. What have you observed when it comes to pediatric mental health and technology habits, or the relationship that patients who you see have with
Yeah,
technology and
it's
devices?
a really interesting and great question. I think a lot of mental health experts, particularly those who work with children, are really concerned and interested in exploring this further. And I think the COVID-19 pandemic has really put a different spin on all of this. If you look at, I as a child and adolescent psychiatrist, I get a lot of my information from my one of the institutions that kind of certifies our work, and that is the American Academy of Child and Adolescent Psychiatrists. And that organization actually put out in February 2020, just before everything shut down, they put out a set of recommendations regarding screen time and regarding use of technology. And I think it's really interesting to look at that list of recommendations. What they had said is for kids aged 2 to 5, to try and limit non-educational screen time to about 1 hour per weekday, and then 3 hours on the weekend days. And then for kids 6 and older, they actually didn't give a recommendation on the number of hours, which I think is really interesting because, this was before the pandemic happened, and, and education switched entirely to being remote as well. And so, even before we had that switch, we had people recognizing that it can be really challenging to determine what is the right amount of screen time for kids, what is healthy and what is not. And I think the other piece of this is that as adults, kids are following our lead. Kids are mirroring our behavior. And it's one thing to say, okay, as a child, I only want you to have this amount of screen time. I only want you to have this amount of technology time. And then they look at the adults, and the adults are, on their phone 24/7. You have an adult that loses their phone and their world collapses. And so, it's not a problem that has an easy solution. But I think what I really like about the approach that you guys take at Virgil's is that using the tool itself, using the technology itself as a way of addressing concerns about that technology is a really unique way of approaching the problem, because then you get buy-in from the very beginning of this is the tool that we're going to use, and this is the tool that in some ways can be problematic for kids. So you get that engagement from the very beginning, and once you have buy-in from a child, once they are interested in the process, the possibilities become much more broad.
And as you mentioned, I mean, I asked about kids, but this is definitely true for adults. Adults as well. I think probably for all of us in different levels, there's room for improvement in terms of sort of moderating our own behavior and tech habits. So I would love to ask you, as somebody who's grown up in Silicon Valley, works at a tech startup and everything else, what do you do to ensure that you have a healthy relationship with technology?
This is a good question. It's I definitely I make sure that I take time each day to be doing something mindful without my phone. So my wife and I will often, we have a nice neighborhood with a lot of unique plant life. And so we will at least once per day do some sort of activity that doesn't involve a screen, that doesn't involve a phone. Often it's going on a walk through the neighborhood, and we leave the phones at home. Which, early on when we started this process was kind of a difficult thing, because there'd always be a little bit of anxiety about what notification am I going to miss, and who am I going to, who's going to call me or something like that. But, making a conscious effort to live in the moment, live in reality, to be mindful of the experiences that are around us at least a little bit every day. And then the second thing is when it comes to sleep. Sleep is such an important aspect of mental health. And I'm, very regularly getting questions from children and adults about how can I help improve my sleep or my child's sleep. And so sleep hygiene techniques and principles really necessitate that in the hour or so before going to bed, that there shouldn't be any use of screens. So that's TV, cell phone, iPad, virtual reality, you name it. In the hour before going to sleep, those things should not be present. And that was actually part of the recommendations in the American Academy of Child and Adolescent Psychiatry guidelines that I'd mentioned earlier. But it's something that I recommend to families a lot, and it's something that I've also, if I'm going to tell other people to do it, I should do it myself too. And so I've implemented that as part of my routine too. no screens for the hour before I go to sleep, and that's produced deeper and more effective sleep for me.
So it sounds like it works.
It needs to be done with a lot of other sleep hygiene techniques, and there's all kinds of things that can be done to improve the quality of sleep that a person gets. But it's amazing, the impact that you can have on a person's life if you get their sleep habits to be more routine and more regular.
Do you know if, like, what's the physiology, like what's actually going on when you're looking at a screen before you go to bed? I don't know if that's known, but
I'm definitely not an expert on this, but my understanding is that it has to do with the type of light that the screen emits. And that's why things like blue light glasses that filter out that blue light that tends to be the most activating, those types of filters, there are applications that you can download on your phone that will sense the time and then implement a blue light filter. A lot of operating systems have these things built in already. But these are some of the things that we know about how light affects us. Ultimately, people have a biological circadian rhythm, a way in which their brain is designed to respond to different stimuli, and it's really based off of the sun setting and what it is like, being outdoors as kind of primitive humans were. And so we have, in our modern world, we've created these artificial lights that make us think that the sun is up when it's not. And then they can make, changes to our internal circadian rhythm, that can be problematic. Interestingly, kind of alternatively, like getting a lot of bright light, like getting sunlight in the mornings or getting bright light. There's even, types of light therapy. There are specific types of light that can be used for people who have seasonal depression or for people who have depression related to bipolar disorder. And some of these types of light can actually, if you get the right amount of exposure at the right time of day in the mornings, you can actually improve those symptoms throughout the day too. So there's a lot of really interesting things about light in the beginning and end of the day that can definitely contribute to a person's mental health.
Is it particular to screen-based light, or is this true for all artificial light?
That's a good question. I'm not an expert on it, and I don't know enough about wavelengths of light to know if the lights that I have on my ceiling are necessarily going to emit that same blue light. But I'd imagine that there probably is some contribution from all different types of light. If we're thinking about it mechanistically, the lights that you have in your house are probably not designed to filter out that blue light. And so I'd imagine that any kind of light can really be contributing to this. But what I know from the evidence is that when we're talking about things like bipolar disorder and seasonal affective disorder, there's a particular type of bright light that, when used in the morning, can be therapeutic, can be really beneficial. And that's not true of every type of light. So your average light in your house is not necessarily going to produce that same effect.
Right. These are the sad lamps,
yes, exactly.
The seasonal affective disorder. Yeah. Interesting. So what you're saying is we should shut off the electricity before sunset.
I don't know if we have to go that far. I think for most people, even taking a pause from electronics for 30 minutes before bedtime is a massive accomplishment, because we are so tied to these dopamine devices, and so it's really It's a hard change to make, even for someone like me who is, who studies this and makes this recommendation to people on a daily basis. It's really it's a hard thing to do.
It's hard, and it's increasingly difficult as we're kind of making this transition from 2D to 3D, whether it's virtual reality or we'll see what Apple comes up with. Some rumors about VR, AR, and I guess spatial computing is kind of the broad umbrella term, but the virtual experiences and virtual content is becoming more compelling. It's becoming more engaging. It's higher fidelity. Now with AI, all this crazy stuff that's going on.
Yeah,
I don't know if you've seen it's DALL-E and the Google controversy, all this kind of stuff, and OpenAI and all these different groups are producing really sort of jaw-dropping artificial intelligence tools. You combine all these things together, and you have the personalization and the fidelity and everything, it makes for just these hyper engaging virtual experiences. And so it becomes increasingly difficult to put down the phone, or in the future, the contact lenses, or whatever else. So understanding that this is kind of the trajectory that we're on, it's not infeasible that 10 years from now, 15 years from now, the sort of the line between reality and virtual reality could start to get quite blurry. So with all that being said, in that future world, do you think there's still a case to be made for reality?
I like this question. Yes, I definitely do think there's a case to be made for reality, and I think it comes in the idea of immersion. You know, one of the things that is so impressive about virtual reality is that the immersion happens with two of our most important senses. You know, it happens. I mean, actually, more than two. We have proprioception in there too, but it happens visually, it happens auditorily, and then it happens with kind of your position sense of the body, or what we call proprioception. And so we're able to, using those different senses, we're able to create experiences that are extremely immersive. And the new technologies that you mentioned, like contact lenses and augmented reality, will make that more immersive. But as even with those very sophisticated versions of the technology, they won't be completely immersive in that they will not have the other senses plugged in. You know, that sort of thing is more like what we've seen in the Matrix, where, you know, you have something that plugs in directly to your brain and attaches to all of the different pieces of an experience. And so the case for reality is that many things that are really great in virtual reality cannot be recreated in virtual reality as things stand right now. But in reality, we have all those things. You can't eat a hamburger you can try and eat a hamburger in virtual reality. You're not going to taste anything. And so, you know, and that goes for a number of different things. You can go on a roller coaster app and kind of feel like you're on a roller coaster visually and from your auditory system. And maybe even you have a chair that moves around, you know, just the right way, but you're not going to have the experience of the wind blowing in your face and, you know, the actual spins and loop-de-loops and things like that. So I think as immersive as technology is, and as impressive as these technologies are becoming, the case for reality is that it's much more immersive. It's truly immersive because all of your senses are present there.
I'm very tempted to push you on the brain computer interface. I mean, point. So
when
60
that
years
stuff
from now,
starts to happen, the question becomes a lot harder to answer. It's like a Black Mirror episode.
I guess it depends on who's running the Matrix. Well, Nick, this was a pleasure. Thank you for answering my sort of silly question there at the end as well. I think this is something that is actually going to be increasingly top of mind. I mean, a lot of us we're sort of in the metaverse right now in some ways, right? Definitely some for all of us to think about. Love what you guys are doing at Little Otter. A few links to share with the audience. Folks can connect with you directly on LinkedIn. So we'll put the URL in the show notes. And then Little Otter is littleotterhealth.com. Is that correct? Awesome. And parents can do that assessment there as well if they're curious to learn if this might be useful or a good fit. And then you guys are also on Instagram, Little Otter Health. Also, if you're a parent and you're thinking about reaching out to Little Otter, you can here's a referral code for a free welcome call, which is a $90 value. LOWELCOMExNNad, which we'll put in the show notes as well.